Okay, thank you. Thank you so much. So thank you everyone for joining again, and thank you Pankaj, Rajesh, Dr. Pankaj, Dr. Rajesh, and Arun for joining and for agreeing to be the panelists today and contributing to the discussion. For all of us who don't know me, my name is Rajveer. I head I4 Mentors Foundation. It's a not-for-profit startup accelerator. We've been working with healthcare startups for about 8 years now, and exclusively focusing on healthcare for the last 2 years. We have started a new initiative. We're trying to build a community of people who are active in healthcare ecosystem to reduce the cost of healthcare. Here we are not just looking at the reducing the cost of treatment, but looking at the complete life cycle. And our intent is try and intervene in the patient life cycle early through early diagnosis, early screening, and through diagnostics as well. And when I say diagnosis, I also mean primary healthcare diagnosis, and not just the tests and so on. And our intent is to bring people together who are working on this technology, as well as people who are in the medical fraternity, people who are working in the NGOs, who are doing a lot of work on the ground. And we believe everybody coming together, people coming together, even policymakers, can actually help solve this problem. We can work with each other, collaborate, support, and collectively find new ideas, new solutions. So thank you again for joining. Appreciate your time on a Saturday afternoon. So I'm just a quick query before we kind of move on. We are using this acronym ABDM here. We've been using it fairly frequently to all our communication. We just wanted to ask folks on the call here, do we know what is ABDM? Do we know what A stands for? Uh, you know, B is Bharat, right? So what is A here? Any guesses here? Anyone here wants to?
Arogya, Arogya.
Arugya, yeah, hi Anil. Thank you. So and Ayushman Bharat or Arogya Bharat? Pankaj, what is it?
Yeah, it's Ayushman Bharat. Ayushman
Ayushman.
Bharat Digital Mission.
Ayushman Bharat. Okay, thank you. So Pankaj has been Pankaj, Rajesh, and Arun. All of them have been part of this entire ecosystem for a while. They were, I think, both Arun and Pankaj were part of the initial team which actually wrote some of the standards and policies. So they'll also take the blame for some of it not working. I hope so. And but the intent is to have a very open and frank and honest discussion so that we can understand where we are, what are the bottlenecks, and how we can improve it further. That's the intent of the dialogue today. So it's an open dialogue. Please feel free to stop us anytime you have any query, and we'll try our best to find a answer your question as honestly as we can. So over to you, Pankaj and Rajesh and Arun. Kindly briefly introduce yourself, and then Pankaj, you can start with your brief presentation.
Yeah, there is another acronym, at least to me, AHA. So along with ABDM, if you could clarify that, I4 understood a little bit.
Yeah, I4, thank you for that. AHA is a partner in this program. AHA stands for Academy of Hospital Administration. So they are like the doctors have generally multiple associations. AHA is one of those associations which focuses on the administration aspect of it. They have 3,000 members countrywide, and plus 50 medical institutes are their members. And so we are working with them for last year and a half, try and inculcate an innovation culture in their organization among their members. Hospitals administration largely focuses on safety, compliance, and innovation is not on their primary agenda. We are trying to inculcate that culture. So we run monthly mentoring program with their doctors, their teams, to encourage innovation. We also do recognition programs with them. Thanks for asking that. Anything else? Anil, Pankaj, over to you.
Yeah, thanks, Rajveer. Dr. Rajesh, if you can introduce yourselves and then Arun, and then I can sort of carry the presentation forward.
Sure, Dr. Pankaj. So, hello everyone. This is Dr. Rajesh Gupta. So, I am coming with 25 years of experience in both supplier and demand side of healthcare technology, which means I have worked in large hospitals, primarily in private sector, and large digital health organizations, primarily from supply side. Currently, I am working as digital health partner with Mind IT Systems in Delhi, as well as program director of Department of Integrated Health Technologies at Silicon University in Odisha. Um, have closely worked with Dr. Pankaj and Arun sir in the past, in particularly in public health domain. So learned a lot from them. Today, I'm hoping that I will be able to contribute to the subject and which will benefit to all. Thank you for having me here.
So my name is Arun Kumbhat, and I've spent, out of a total working life of about 43 years, I've spent the last 25 in healthcare. And it's across the length and breadth of everything in healthcare, starting with bulk drugs going on to digitalization. It includes stints in public policy and government affairs, and guilty as accused in terms of contributing to the digital health infrastructure in India. So, yeah, thank you.
All right. So thanks, Arun. Thanks, Dr. Rajesh. My background, I come from a clinical background. I started out as a dentist. I shifted into technology. I have a master's in computers and an MBA from IIM Bangalore. When I shifted into technology, I started as a programmer all over again, and then worked my way up. I've spent about 12 years in US and Canada doing digital health transformations, now what is called as hospital automation for large hospitals in the US, about 5 of them in the US, and then up north in Canada, and then Saudi, and then back to India. In India, I have been working in the private sector on hospital automation, and with the government, as Rajbir said, been part of the team that has written up the standards behind the Ayushman Bharat Digital Mission. We were part of the initial team that started writing up the standard when the ABDM name also wasn't there. So we were told that, we have to create something like that.
When the term digital health did not exist.
Correct. Even digital health did not exist. True. So we started writing all those standards, and of course, it's taken a life of its own. Frankly speaking, when I started working on it, I never thought it will get a life of its own and it will become so big. But thanks to God, and I think there are things that have a way of its own, and I'm glad that it has taken a life of its own. So with that background, I will jump into the presentation. I and Arun also run an organization called Libra Social Research Foundation. Basically, all the work that we did in writing up the standards and everything, we bundled it up into Libra Social. And it is a not-for-profit organization. We do a whole lot of different activities under it. But today, I'm going to focus on ABDM and the data imperative. So it's affordability and accessibility is the focus today. For affordability, the most important thing is risk pooling, because that's the way to bring affordability rather than subsidizing. And also accessibility, the way to actually make healthcare accessible is to expand the primary care at the bottom of the pyramid. So with those two fundamentals, I will get into the little bit of details. So Ayushman Bharat, actually, most of the people don't even know the full form of ABDM, and since they don't know the full form of ABDM, I don't expect anyone to know the construct of Ayushman Bharat. Ayushman Bharat actually is an initiative by the government of India under which there are 4 pillars. Pillar 1 is the accessibility pillar, which is basically expanding the primary care at the bottom of the pyramid. And the earlier, it was called as health and wellness centers. Now it's been rebranded to Arogya Mandirs, Ayushman Arogya Mandir. But to actually simplify it, it is primary care. Primary care at the bottom of the pyramid. Some 150,000 health and wellness centers have to be set up, and they are being set up on the government side. But then on the private sector side, it has linkages with the primary care on the private sector. But unfortunately, in the last about 10, 15, 20 years, we've seen the primary care dwindling on the private sector side. New doctors have stopped going into private practice. They would rather do a specialization and go and work in a hospital rather than doing a private practice. But nevertheless, government continues to push the bottom of the pyramid in terms of primary healthcare. On the second pillar is the financial protection and affordability. Now, the best way of bringing affordability, as I said earlier, is risk pooling. What do you mean by risk pooling is that you basically increase the size of the population that is covered. And what happens is the risk gets sort of divided across the population. So larger the population, lower the risk, and obviously lower the premium and higher the coverage. So that's the fundamental principle of risk pooling. And that's the standard principle that exists all over the world. Unfortunately, in India, we have done pretty poorly on risk pooling. The health insurance and the various kinds of payer models have not really flourished. We can have a separate discussion in terms of why it didn't happen and all that. But the fact of the matter is it did not. Now, government took the initiative of plugging the gap by bringing in PMJ. PMJ is supposed to cover about 40% of the population, which is economically weaker sections, and which translates to about 500 million citizens. So the third pillar is building hospitals. It is called as Ayushman Bharat Infrastructure Mission. And this one is basically building hospitals at district levels and also larger tertiary care hospitals. So medical colleges and upgradation of district hospitals to medical colleges, etc. A lot is being done here because you need referrals. So you have to move the patient from the primary care to a referral center. And unless you have those referral centers built up, how are you going to do it? Now, ABDM is important in all three of them because you need to have enough data and you need to have a credible information in terms of which one to be developed where. You need to have information about disease burden, about the demography, and also you need to have information in terms of the healthcare facilities, what kind of healthcare facility needs to be located at which part of India to serve what kind of population, to serve what kind of disease burden. And unfortunately, in India, traditionally, we don't have the data to back up all this because we collected a lot of data from hospitals, but then all of it or most of it is handwritten, or if it is electronic, it is not in standard format. So it is not analyzable. It's very difficult to analyze data that is written on paper. You can scan it, but then machines can't read it. So that's been the biggest challenge, and that is the reason ABDM was constituted, to standardize the data, to bring the data across all the parts of the ecosystem, and then build the basis on which you can do the actuarial analysis for the risk pooling, and also do the epidemiology analysis on which you can use for building all the health infrastructure. So as I already mentioned, actuarial analysis is...
Can we ask question, or we can wait until the end? Whatever works.
Whatever works.
Yeah,
Okay. So just a quick one. I'm just trying to get the whole picture. So the core proposition is to be able to create a joint or a collective data scaffolding, so that then you get both the input from all across, and then you are able to reach out with the and look for the outcome. Is that a fair understanding? Because there are 4 different pillars you have talked about. I'm just trying to create what is the holistic picture. Where are we heading?
If you would wait for a couple of slides, and I think that question will get answered.
Okay, sure. All right, sure.
All right. So if the question still stands at the end, please voice it once again, and I will try to elaborate. So, as I was saying that, there is a lot of actuarial analysis that need to be done. And for that, the data is required. The health insurance currently don't have the data. And that is the reason they're not able to, expand the coverage. The numbers are so small that, we've not been able to go beyond the tier 1 cities of India. The health insurance penetration beyond the tier 1 is really, really small. So that is where the gap is trying to, or the government is trying to plug the gap by bringing in PMJ. And PMJ is supposed to cover about 500 million population. But there also rolling out the cards has been sort of slow, because who is eligible? Again, that data is so scantily available. And the last census was 2011, and the census has not happened after that. It's currently going on. But then, we have to sort of make do with whatever data is available. So, so those are the issues. So that is the reason ABDM was constituted, that, we have quality data. If you have data quality and data governance, then all of this is taken care of. Same way, if you look at on the outpatient side, the coverage of the health insurance and outpatient is not there. And most of it is out of pocket expenses, because, again, you don't, the health insurance doesn't know how much is the risk that needs to be covered on the outpatient side. Again, it's all data dependent. They have to figure out as to what is the risk, and only then they'll be able to provide the coverage. So again, that is where the data sort of plays a role. But also, the other thing is in terms of reaching to the bottom of the pyramid. So all the healthcare, human resource, as well as the facilities are unable to reach to the bottom of the pyramid. So you take the help of technology, and that is where ABDM again comes in. So ABDM has laid out a whole lot of building blocks which will help you go to the bottom of the pyramid. And on the health insurance side, there are things like National Health Claims Exchange that has been put forward, which is standardized claims. Now, if you are able to standardize the claim, it helps in terms of bringing the adjudication faster, and of course the wait times are reduced for the patient, and the money comes into the bank of the hospital faster. So that's the model, the National Health Claim Exchange, that has been put out. And on the other side, as I mentioned, that to reach to the bottom of the pyramid, electronic health record standards with all the terminology standards and all the identifiers need to be in place, so that you are able to do a standardized electronic health records and telemedicine to reach at the bottom of the pyramid, wherever the patient is. For that, as I was mentioning, all the IDs, so there's something called ABHA ID. ABHA is the unique ID for the patient. And then you have registries, which is the health facility registry, the healthcare professional registry, and so on and so forth. There are a list of registries. Drug index is there, and then you have the lab codes. So, and then you have the terminology standards. So you need all of this to come together, so that you'll be able to put together credible claims, which will be electronically readable, and it will sort of give the benefit to the patient as well as to the hospital. In terms of opportunities and way forward, quickly I'll just cover this, and then
I was just wondering, you were using
Maybe we can
some
pause. Yeah, maybe we can pause here, and take the questions.
a
Yeah,
complete
go
meaning
ahead.
of what is ABHA, and then before that, if we go back to a few other slides, because just to give the background that we have an eye hospital, charitable eye hospital in Bagpat, and we started to get a lot of Ayushman patients, and we had been finding something really good about it, but at the same time, there were few other things against which we had been struggling a lot. But I need to understand this because we do the eye camps, and otherwise also we do the patients who are walking in as outpatients, and then we ask them if they have Ayushman Bharat card, then we process them. So what is ABHA ID? And before that, you had used another acronym, which I don't know what does it mean.
Do you mean National Health Claims
Yes.
Exchange?
Yes, NHCX.
Right.
We got
Claim
confused.
exchange.
Sorry,
Okay.
it's the first time we are joining, so a little bit more curious than others.
No, that's
Yeah,
fine. That's fine.
yeah.
So
It helps everyone. It helps everyone, not to worry.
It helps everyone. Yeah, absolutely. That's the idea. Yeah.
Sure. So let me try explaining. So I'll actually have to go back a couple of slides to the first slide because what you're saying as PMJ card or the Ayushman Bharat card is a health insurance card given by PMJ, Pradhan Mantri Jan Arogya Yojana.
Yeah.
So it is actually a 5 lakh rupee coverage per family per year, and that is the card that people must be bringing to you. But what happens is, for you to be able to service that, you need two things. One is that you will need a hospital information system that will have the ABDM standards built into it. You can do it without it also, but then it becomes completely electronic. It becomes like click, click, click. If you are able to have a ABDM enabled hospital information system.
Yep.
Now, if you don't have it, still you can do it. You can scan your records, upload, and all that thing is possible in PMJ. But then the question that you asked was the ABHA. ABHA is a unique ID given to all people in India. Now we have about 100 crore ABHA IDs generated for the population in India under ABDM. So ABHA is a unique ID under ABDM. So ABHA is something that you anyway require for doing anything, irrespective of whether it is covered under PMJ or not.
You can go to Arogya Setu 2.0 app, and you can actually generate your own ABHA ID.
Correct.
Yeah. Arogya Setu, you remember during the COVID times, there was an application called Arogya Setu, which was used for locating the nearest COVID center, immunization center. Here, the same under the same name. Now you can actually, if you you can download the app and generate your own ABHA. You can do it for your patients as well if they don't have
So
it.
everywhere where you see
Pankaj, you also
AB,
had
it
a
is Ayushman Bharat.
Sorry, go ahead, Arun. Yeah.
So wherever you see
Yeah, but
AB in this presentation, it stands for Ayushman Bharat.
And what is HA here?
Health account, if I'm not wrong.
Health account.
Yeah. So ABHA, in a very simple analogy, is your Aadhaar card for health services, if we
Okay.
can say
Alright,
so.
okay.
Got it.
Right?
And it is applicable to everyone, irrespective of their age and their financial backgrounds.
Yes.
Everyone.
Yes.
Everyone.
Yes.
And when they have this card, irrespective of whether they have some private insurances.
Irrespective,
Yes.
ma'am, it is your health account for,
And so it
for
doesn't
life.
affect like
For life. It's
somebody
unique.
who's working in government institutions, so they get CGHS and then ESI insurance and other insurances. So irrespective of everything, you still can have ABHA
Yes.
ID.
So,
Yes.
Aadhaar.
Okay,
Aadhaar
thank
for
you. Thank you so much.
Yeah, absolutely. Actually, ABHA is a unique identifier given to any citizen of India um, for healthcare purposes. You can, as Dr. Rajesh said, it is like an Aadhaar for healthcare. But with an added advantage that it has a storage space which Aadhaar does not have. So Aadhaar has a storage space at the back end, so you can link your medical records with Aadhaar and it will stay in the storage. At least the storage will have linkages to your medical records like you have in hospital. So you could link all your medical records to the Aadhaar of the patients, and patient can go anywhere. They, of course, the Aadhaar will not have all the details in the record, but the Aadhaar will have a record that so and so record exists with so and so hospital.
And does it exist through all the government hospitals and the private institutions as well?
Yes.
But what I realize is that many of the private institutions now, they are not taking the Ayushman Bharat patients because they get limited by the amount of money the government pays them. So we had been finding it very difficult. Like in Delhi, most of the private institutions, they don't accept it, though they are registered with the Ayushman Bharat, but they would just reject the patients who are coming to their hospital for the services.
Yeah. So you'll have to sort of differentiate, as I said, between the Ayushman Bharat card and the Aadhaar ID. Because Aadhaar ID is for everyone, but Ayushman Bharat card is only for that coverage, 5 lakh rupee coverage.
Yeah.
So Pankaj, can I ask you a question?
Bindu ji has
1 minute. Dr. Bindu, please wait for a couple of minutes.
Yeah, sure.
Thanks for joining, but just 1 minute. Yeah, we have a couple of other people who are holding their hands. Actually, there is also lack of clarity on the schemes, on the Government of India schemes. That's another challenge we have. That's the reason why a lot of hospitals actually reject it. It may not be because of lack of desire to service. It's also because of lack of clarity. So we are working with one girl in Bombay, a doctor, who is actually helping a lot of patients in Bombay. She's created an app helping patients access these schemes. Apparently in Maharashtra or in Bombay itself, there are 17 such schemes, not just one, 17 such schemes that the patients can use for subsidized healthcare. So I don't know what's the number in Delhi. So maybe one of the challenges that she found was that hospitals themselves are not aware as to who is eligible, what are the what the details about the scheme, how to take advantage of it. And the hospitals that are aware, they really welcome the patients because for them it becomes a revenue source. So what we'll do is maybe we'll try and organize another session which only focuses on that, on the different kinds of schemes. We'll invite that girl. Her name is Diya Shah, based in Bombay. And she'll talk about the Bombay experience. We'll also try to find somebody who's working in Delhi on that area. So Pankaj will take your help with that. Yeah.
Yeah, sure. No, absolutely. Valid point. Actually, what happens is at the national level, PMJ, Pradhan Mantri Jan Arogya Yojana, that's like an umbrella. And then you have state level schemes like, Rajveer mentioned in Maharashtra. There are various schemes at the state level. So now slowly everything is getting linked up because 5 lakh rupee coverage is provided by the government, central government, and then X amount is added by the state government. So what is covered, what is not covered, what is covered here, what is not covered there. All those things are being worked out step by step. So that's going on in the background. But yeah, absolutely right. Right now there are multiple schemes.
If I may,
schemes also keep changing. Schemes also keep changing. Their eligibility keeps changing. The coverage keeps changing. That's another unfortunate aspect. So yeah, Rajesh, please.
If I may add, the question was why some private hospitals are rejecting the patient. That was the question. See, while scheme is rolled out countrywide, health is a state subject, so that itself creates a political issue, which some states adopt it, some states don't adopt it. But when it comes to private hospitals, PMJ schemes payment might not be viable for them to cater to those patients. Similar to what CGHS used to offer. Now CGHS prices are revised, so it is in better proposition now. the primary reason, to be very honest, is the payment scheme, the price itself that is being reimbursed is not viable for private hospitals, especially those which have to maintain very high quality of care and infrastructure. So obviously they have no choice but to reject. So that is one primary reason which I'm able to tell you very, very openly.
Yeah, so on that one, actually, Dr. Rajesh, if I may add, the way the government calculates is slightly different as compared to the way private hospitals look at it. So you see, the government gives a lot of subsidies to the hospital. So they provide free land, free electricity, free water, tax holidays to the hospital, tax holidays to the doctor, no GST for clinical services, etc., etc. Now, the government calculates all of that and says, now we are giving you these subsidies any which way. So now for our schemes, you will get a lower payment per procedure. Now, but if you calculate it as a total, it works out to be better than what you are going to be paid in the private sector per procedure, because anyway the subsidies have been given.
Maybe we don't know, but yeah, we'll learn slowly.
I think
So it's a calculation error.
Yeah, there is also the question of turnaround times, which of course the ABDM solutions can help reduce, but turnaround times is also an issue.
No,
I mean, see,
have
if
been
there are
facing
two
it every
patients,
day. I have been facing it every day, and like the outpatients are free for them, investigations are free for them, and we are a charitable hospital. We didn't get the free land. We got the seed money, and after working in that area for 20 years myself over there, and finally I got the seed money, and I started with this hospital. So I know when we organize the camps, we do the free surgeries whenever the patients are coming through the camps, and the patients who are walking through the outpatient, we normally do the counseling and see how does it go. But we had been finding it that, with the Ayushman Bharat, we are happy because we are doing a lot of Ayushman Bharat surgeries. And these are the patients who have been traveling to Bagpat from Delhi, because in Delhi they were rejected as Mr. Rajesh Gupta had doctor. He said that the private institutions feel that they cannot, is not viable for their services. But for us, who is a charitable hospital, we find that we are struggling because we don't get any private patients. Everything goes under the Ayushman Bharat.
Also, ma'am, if I have,
can we just move on? Don't mind. We need to move on. We'll come back to this maybe later, right? Sorry, Rajesh. So we have Dr. Ketan also. Dr. Bindu, I'll come to you. Dr. Ketan has raised his hand before you. Dr. Ketan, are you still there? Pyramid Map.
Yeah, I am there. Can I speak?
We have
Can you hear me? Yeah. So my query is that whatever we just said, that ABDM and
Four pillars,
empowering the primary care doctors and everything, creating hospitals at a district level. But this is going to be a little bit of a long-term thing, in the sense it's not going to be something overnight, one. Second thing, I'm sure that we do realize that even if we create the hospitals or create the hardware, specialists are not going to the smaller hospitals so easily. I mean, the district hospitals. They've created medical colleges, but medical colleges don't have teachers. Now, we, on the other hand, have a large pool of doctors in the private sector. And I'm sure we are well aware that almost 70% of the patients also, I mean, that's the figure that I have got from the thing, that 70% of the patients are also not going to government sector clinics or hospitals, but they are going to private sector. So what is being done to get these people in the complete healthcare domain? I mean, they are a completely unorganized lot. You are well aware of that. They are completely unorganized. And we are talking of 70% of the population is seeking healthcare from an unorganized system. So is some attempt being made to streamline these people and streamline the flow of patients from the unorganized sector, private clinics? Although you say that doctors are not going to but the Ayush doctors are going to the villages, and the MBBS doctors are not going. I'm fully aware. But there are enough number of Ayush doctors even in the villages and in the smaller rural areas.
Yeah.
So what can be, is any attempt being done to empower these people? And that, as I said, is catering to whether it is 60% or 70%, but a substantial population. So are we looking at something on that side? Because we are attempting to do that. We are attempting to do that in Pyramid. But we are facing lots of challenges because there is no incentive for these people to get organized. So can we do something to...
Yeah. So Dr. Ketan, when you talk about empowerment, are you saying empowerment in terms of digital infrastructure or medical infrastructure or training skills? What kind of empowerment?
No, clinical empowerment. I'm talking of clinical empowerment. That if we can give them some incentive to clinically empower themselves, so that because that's a large population we are looking at.
Yeah. No, absolutely. I completely agree. Actually, the way to organize them, actually, there are efforts to organize the unorganized healthcare sector. Some green shoots are there, like for example, using telemedicine and the retail kind of outreach programs. So you may have heard about Farm Easy, 1mg. Those kind of models are emerging to organize the unorganized clinics and unorganized sector in healthcare, to bring them under an organized umbrella. But those efforts are still sort of green shoots and yet to scale to a level where it can reach everyone. But the effort has borne fruit, and it is something that is a viable model. That's what I can sort of add to what you said.
Arun and Rajesh, do you want to come in? Do you have any comments on that?
No, I think this is a very important topic. But the very simple question is that if today I have someone at my home who needs healthcare services, whether I'm going to take that person to a private hospital or to government hospital, probably I will immediately take them to a private hospital because of accessibility, quality, because I'm able to afford it. So here the question is why doctors are attracted more towards private hospital is for the same reason. This is a separate topic altogether, probably little off topic from our agenda today.
Yeah,
but
agreed.
It's interesting topic to discuss. So that's just 2 cents from my side.
I'm not saying only the doctors getting attracted, the patients are getting attracted. What I'm trying to say is about the patients.
Because of the same reason, because I will myself take my patients to private.
Sir, when we are looking at 60% of the population, that means we are not looking at all affording population. My problem is there.
Yeah, there is room for mediated telemedicine to bridge this gap, right? Which will empower the Ayush doctor as well in a way, because he can do what he can do, and for what he can't, there's always the possibility of using mediated telemedicine to connect to a doctor somewhere. But I think it to my mind, and a little more of a philosophical answer is that what happens is every stakeholder in the healthcare system today works as if it were not a continuum. It is a continuum, right? And they don't look beyond their immediate thing. They don't realize how they fit into the whole thing. Everyone is a part of the healthcare system, and therefore that lateral cooperation that is required to make this work is not endemic to the system. It needs to be cultivated. It sounds a bit philosophical, but I think that's a problem to address.
No, I think, Arun, the point here is in each of these, I know what Dr. Ketan has been trying to do. The doctors at the primary health centers in the private sector, in the tier 3 towns, semi-urban, rural areas, their education and skilling hasn't really scaled. Their primary source of education is the person who comes to give them medicines. That's the primary source of education. And therefore, they kind of look at those 5 or 6 or 10 group of diseases which they can cure and for which the handily knowledge and medicine supply is available. So is there a way to empower them, scale them? It's a and maybe because that's where probably the root cause is. If you can actually have a very robust PHCs, primary health centers, then a lot of early diagnosis happens, and people do get an early treatment, or they get initial treatment at least, if not absolutely clear roadmap. So if Dr. Ketan, come back to you on that. Let's do another session. Maybe we intend to do another session only on PHC and see how we can strengthen that. That's a good point. The PHC include both private and government setups. So let's talk about that in another session. Dr. Bindu.
Yeah, thank you very much, Pankaj ji. You gave a lot of good information. I'm from USA and friend of Rajbir. So I'm attending and want to share my experience. And I'm working with the IIT and Wheels for charitable function. Few things which I really believe it will work. Once you mentioned about lack of data. So we have implemented at a lot of our centers, which is no cost to the consumer. We strongly believe we all got education from Indian government, Indian taxpayer. So time, talent, and treasure sharing. My background is a cardiology, intervention medicine, MBA, and working with the Pennsylvania governor. Problems we have similar to you is what we took us a while to implement. Number one, what you alluded is Arogya Mandir. Ayushman Arogya Mandir. There are 187,000 of them. Most of people are not aware of what is the function and where they are located. So we are trying to get that by PIN code so people can be aware of what they are meant for and they can get a primary healthcare services for preventive healthcare. Second thing which I have noticed, which is not necessarily right, but you can implement, you can influence Modi ji to change it because everything for inpatient is costing you a lot of money. So first, everything is outpatient. Even I do the angioplasty, they are sent in 2 months, 2 hours back home. So if we try to adopt, Arogyaman Bharat Yojana for not only for inpatient, there's unnecessary cost, which can be reduced. Second thing, what you talk about DRGs, diagnosis related group. So if we try to bring them and get reimbursement to the doctors and to the hospital, it will be accountable. Third thing we are providing them is a Z code. Z codes are very important for your disease-related diagnosis and income grade group. So with Rajbir, we are working with Prashant, we are working to get all this data at IIT Ropar. Also, we are implementing what you call, community health program for our doctors. Each medical student has 5 family adopted for 5.5 years. So we are trying to get a data. We are giving them the software called My Smart Care Portal Doc. Is free. So they can get a data for the 5 families for 5.5 years. That way we can scan almost all the villages. And our attempt is to use the technology-enabled solution with the IIT and the doctors will stand for that. So we are trying to do that. And thing which I wanted you to add is to every doctor should use the CPT code and ICD-10 10 code. So once you start giving the reimbursement to the doctor based on CPT code, they'll be more interested to go to Arogya Mandir and start providing the care for preventive health care. So I think you gave a lot of education to me, at least, because I don't stay here. I'm in USA. I just came back today and Rajbir asked me to join. So I think it's an amazing attempt. And we would love to work with you and give you a lot of failed ideas from USA we should not implement, because Medicaid, we have same issue. Doctors don't take it because they don't pay them based on the cost. So we should try to pay the doctor based on the cost analysis. And DRGs, a lot of doctors are saying if they have business like charitable hospital, they are running for, they shouldn't have operational money come from the services. Donation money can use for people who don't have money. But we need to balance it out like what we have Medicare and Medicaid in USA. So you're making amazing bandwidth for and you are having the largest insurance scheme in the world. So I think we are going to learn, but without the electronic health record, it's not going to be feasible. And Rajbir and we are working for a lot of villages where we would love to work with you through IIT.
Right.
Thank you, Dr. Bindu. Thank you so much. I'll connect you with Pankaj after the discussion.
If I can just add one thing, Rajbir, just one point to Dr. Bindu. Dr. Bindu, you mentioned about US and then the terminology standards and everything. So Ayushman Bharat is exactly about terminology standards. Just that we are not using the US terminology standard, we are using the open source ones, which are from WHO, because we didn't want to pay a hefty price to USA for every time we use it. So we are not using CPT. Instead of CPT, we have the other standards, which are open source, and ICD-11, ICD-10, SNOMEDs, lying, drug index, all of that is built in. So that's part of it. And the second thing is in terms of health insurance models in the US, you have electronic data interchange and X12 standards over there. So there was a question in between about what is NHCX, National Health Claims Exchange. That is exactly the same principle. It is exactly the same principle as EDI X12 of US. So I just wanted to sort of...
No, I saw that. You are amazing. And what I was saying, that if physician get reimbursed for adequate amount, everybody will accept the insurance, because they should not make a lot of money, but they should not lose the money.
Sure.
And that's what I'm hearing from a lot of doctors who are practicing. We should try to make them solvent. At the same time, whatever you talked about, indirect or direct cost, but charitable people don't get the money like government hospital gets. So I think we need to have, it's a learning for hearing all other people we're talking.
Thank you, Dr. Bindu. Rajesh, Arun, do you have any comments on that?
No, I think it's
No
been
comments.
adequately.
Okay, thank you. So thank you. I think one more thing, maybe Pankaj, you want to come in and talk about is, we briefly talked about registries. I think registries are very powerful. Maybe you should expand on that concept a little bit.
Sure.
Plus, you have an overarching architecture slide, not the technology architecture, but the overall business architecture slide on the ABDM program. I think that is also very powerful. If you could share those as well, that could help. Can you please?
Actually, I took that off because that was too overwhelming. I thought, it'll be very,
but I think it provides a good perspective. We have very, educated
so
laws here.
Let me see if I can pull it out. One minute. Yeah. So I have it here. Give me a second. This is the whole architecture. Actually, it's very overwhelming.
If you could start from the earlier slide 11, the journey part, right? The journey is also very educated.
Okay, all right. So actually, as you
can you reduce that picture in picture, please? The corner.
I will try doing it. I hope this helps. Yeah. Right. So actually, the journey, as I mentioned, that started working with the government of India about 10 years back on the standards, and when we started working on it, there's an organization called National Health System Resource Center, NHSRC. They used to do a whole lot of training for districts and sub-district levels for something called HMIS systems that used to exist in those days. Now, HMIS was basically for tracking the pregnant women and giving them services. So I started trying to standardize that. That was way back in 2011, and then wrote up a report called Public Health IT Study Report, where we pointed out that different healthcare systems, they don't talk to each other. What you need is standards. So Ministry of Health and Ministry of IT need to get together and write up these standards. This was in 2011. In 2013, there were two committees that were created. One was an EHR standard committee, and the second was the MDDS, which is Metadata Data Standards for Health. So I got the opportunity to lead the task force that wrote the metadata standard, and I was a consultant to the EHR standards committee. So those were done as early days. Fast forward to 2018, the government changed, the type of, the governance model changed, and Modi ji's government brought in something called Ayushman Bharat. And for Ayushman Bharat to take root, the most important thing was to have granular level data with data standards built into it. And that is the reason, MDDS was notified, and then, there was a whole committee that was built up And that's where, Arun and so many other people joined in. I later on roped in Dr. Rajesh also for some of the work that we were doing. So we wrote up all the standards and then supported in writing the digital health standard, which is called as National Digital Health Blueprint. Then the government came forward to institutionalize it under the National Health Authority. That was called the National Digital Health Mission. It was upgraded by the Prime Minister to Ayushman Bharat Digital Mission. So it's called, the full name is PM Pradhan Mantri's Ayushman Bharat Digital Mission. So it is a mission mode project working directly under the Prime Minister's office. So a whole lot of work has gone on in that. So it's been a 10 years journey. And to do that, the one big thing we did was we brought in startups from the ecosystem that could be early adopters of the standard, because we didn't want to say anything that was not tested. So they became our test bed and the early adopters. About 40 startups came forward. They are today all ABDM certified startups, and they are the early movers. They are available. So any hospital wants a HMIS system that is ABDM certified. So today about 240 of those are available. So that was the way it all started. And in terms of what Rajbir was saying, I'll just go to the architecture. It's a little overwhelming. So, if you look at the middle layer on the left-hand side, you have the registries. So Health ID, at that time it was called Health ID. Now it's been called as the ABHA ID, which we've already discussed. You have the Healthcare Professional Registry, which is basically a registry for all the healthcare professionals. So what happens is right now, all the doctors, nurses, pharmacists, they are registered at state levels. So you don't have a national level registry. So the work is to roll up all of it into a national registry. And I think in about 8 lakh healthcare professionals are already registered in the healthcare professional registry. And then if you look at professionals which are physiotherapists and many paramedics, they don't even have a registry. So, but then they are important component of the healthcare system. They need to be brought in and put into the healthcare profession. So that's the one. Then healthcare facility registry. Healthcare facility registry is to have all the facilities in India, all the healthcare facility, whether they are clinics, they are pharmacies, labs, hospitals. You have to have certain parameters around it and a unique identifier so that you can identify where they are, who runs them, what kind of facilities are there. So there's a healthcare facility registry now created at the national level. I don't know exact number right now. I can share it with you on the there's a dashboard which gives you a live data in terms of how many healthcare facilities are already registered. And then you have the drug index, which is a drug registry, all the drugs in terms of the generics as well as the
Brand name
names. They are all sort of registered into a drug registry, which was recently released. And then it was really tough to bring everything together. Again, the same issue. You have registries for drugs at the state level, but national level did not exist. So, but imagine if you have to do a telemedicine and you in the telemedicine consult you write a drug, and that drug means something else in another state, you have an issue, or it doesn't exist in another state, you have an issue. So you needed a national drug registry. Same way the lab tests, you need a national lab test registry. Now it's been called as the LOINC drug codes. So that's been rolled out. I already talked about the ICD-10s and the terminology standards and everything, so which have also been rolled out, so that the health information exchange can be enabled across different systems. And that also carries forward for the health claims, because there is an e-claim standard, which is machine readable standard now, that has been put forward. So it becomes just like your UPI. So when you sort of, do a UPI transaction, the money goes from your bank straight to the other bank. And the National Health Claim Exchange actually becomes like that. If your claims are machine readable, there's no human in between. It straight away goes from one system to the other. It gets adjudicated automatically. The payment gets approved automatically. And, so it becomes like a UPI transaction. So all that is in place. Now, if you look at the layers on top, I'll skip the APIs, though that's a little technical in nature. But the top level layer, if you see, there's Arogya Setu there. That's what Rajveer was talking about. So Arogya Setu was an app that was used extensively in the COVID times. Now that's been upgraded and it has become Arogya Setu 2.0, which is basically an app which is a PHR, personal health record that the people can use to actually put their records inside it, so they can build an Abha. Now AI has been put into it. AI is able to read non-standard data elements, non-standard records, and convert it into standard records. So that's also there in that. eSanjeevani is a telemedicine platform that has again AI built into it. So a lot of the consultations can be AI enabled. So it's like an AI chatbot with a physician attached to it. So the physician's job becomes easier because the AI is already there. There are many other apps that are sort of, as I mentioned, 250 or 240 odd apps which are certified as ABDM standard. They're already put out there. HMIS systems, recently a CDAC eSushruut, which is an HMIS system certified on the ABDM standard, has been put out as a free one available. Anybody can use it. And similarly, there's a lab information system also from eSushruut that has become available. So these are actually, if you look at it like the Bheem app of UPI. If you remember when UPI was launched, all these Google Pays and Phone Pays did not exist. So the government created something called a Bheem app. And that was like a technology demonstrator. So all of these are technology demonstrators. It is for the market to come forward and build their own applications using these APIs. And that's the ecosystem that has been put forward. The bottommost layer is in data privacy and data security. You have the consent artifacts, you have Aadhaar, and so many other things. So we leave that aside for now. But then, that's the architecture. It's quite overwhelming. Sorry for burdening you with all these details.
I think this is amazing. I learned so much. You are way ahead of whatever I have known. But I think one thing, if I may request, what your lab information management system, one of the things which happened over 50 years in USA after failed experiment, they were standardized and mandated that all the diagnostic center, all the private labs, they have to follow LabCorp and the another company which are having 90% market share. They have to follow the standard so everybody can have a data for portability. Anywhere I get my lab done, they'll be standardized. And they will have a trend for me so I can compare and the data transfer it to my ordering doctor same day, same time. So I think this is something what you're working on, all this top portal. And Dr. Sood and I have worked together. eSanjeevani Telemanas is amazing application. Amazing. I think this was very thorough, what you've done. Hopefully people appreciate what you are doing. This is amazing standard. You have worked at it.
Thank you so much. Thank you so much. And WHO has actually come forward and put ABDM as a reference standard for global adoption. It's being relabeled as Digital Public Infrastructure for Health, DPIH.
Amazing. And one other person you should work with is Rajendra Pratap Gupta, whom Rajbir knows. He's my dear buddy for digital health movement in the world. He would appreciate what you are doing. And DPDP rules is another thing which I want to make sure the people understand. A lot of people which I've talked, they don't understand DPDP rule regulation.
Yeah.
Privacy, data protection.
Yeah, we'll do a session on DPDP as well, Dr. Bindu. Thank you so much. Pankaj, we just want to go back to Anil. I think he has another query.
Sure.
Dr. Anil, are you Dr. Anil? Hello.
No, I'm only Anil, and
Uh-huh.
she is Dr. Manju,
All right. So
and we are joining you from Sydney, Australia.
from Australia.
Oh, okay. That's interesting. Thank you.
So
Please go ahead. Yeah.
my question was, you were talking about primary health centers because though I live in Australia, but I had worked in India for a very long time, and I'm an eye specialist. And I had worked in, I don't know how many of you are from Delhi or from UP, but I
I
have
am here.
worked in Bagpat village, Kekra, around that area for last 20 years, organizing camps and everything. So I know the system pretty well. NPCB system, which we struggled and finally we gave up. There was so much. But with the Ayushman, the good part is that whenever we enroll the patients, means it needs a lot of paperwork. So we have got 3 staff only for Ayushman Bharat. And they are not paid by Ayushman Bharat. We pay them to do all the paperwork. So that is one thing which I'm concerned about. Second is that although we get our money, but not in time. Like there could be a backup of almost the last time when we had a meeting, there was a backup for about 200 patients we didn't get the money for. And now when they recheck and then finally they release. I must say, compared to NPCB, Ayushman Bharat is doing really good. And secondly, we could never afford to do the retinal surgeries because our patients could not afford any retinal detachment surgery. After it has been included in the Ayushman Bharat, at my hospital, I have established a retina clinic and the surgical retina, and we are operating them though at a lesser price. So we had to pay, the hospital has to pay the retinal surgeon out of their pocket. But at least because of a charitable institution, we are looking after patients who have retinal problem, then to be get lost in the city. Thirdly, with the squints, we had been able to take care. And lately I understood that now the Ayushman Bharat is expanding to include all the teachers. Am I right?
Yeah, I mean, different population categories are getting included. So right now the focus is on disability and senior citizens. The next one will be teachers and a couple of others.
Yeah. So we are pretty happy with the Ayushman Bharat. The shortcomings are, first is the digital thing which you all are discussing. And I know we haven't got hands on those digital things. Second is primary health centers. We don't get patient referred by ASHA. Although we had approached them, but somehow there is some communication gap over there. So we get our own people to go and knock the doors and then get the patients to the hospital. So I'm just talking about the ground reality, what we had been doing and where the Ayushman Bharat has helped us and where, it's sort of...
It has not.
It has not, that's all.
I mean, that's an
Yeah,
amazing...
it's pretty good to understand a little bit more. I
More
come
of the
from IIT background and pretty deep in AI and API and all that. So that bit we will discuss later on, but very happy to learn.
Yeah.
Being the
Thank
first.
you. Yeah.
I don't want to miss out on congratulating you for what you are doing.
Yeah.
Right? Regardless of all the rest of the stuff that we are discussing, you're doing a phenomenal job. And that needs to be said.
Thank you. And that is why I always look forward to, and with the Ayushman, we are happy because at least there is no dropouts on the payments, those things. And then our staff is running to their offices and asking them, requesting them as we did with the NPCB.
Ma'am, I urge you to adopt the National Health Claims Exchange also, and that will ease the, all the paperwork, everything else.
We'll understand.
I think, I'll understand because I'm attending this meeting being forwarded by Yogesh Andle.
Okay.
So Yogesh is one connecting everyone. And Pankaj, did you mention about a senior citizen scheme now which is implemented? How many people are going to benefit with 70 plus?
So so I don't know the exact number, but last I checked was, I think some over 10 million senior citizens already enrolled.
That opened the door for her and a lot of people who are doing the work.
Yeah.
Absolutely, so because we do the camps. So now we have started asking their age so that the surgeries which we were doing free from the camps, now we can put them under Ayushman Bharat. and then we get some money, although it's not substantial, but every penny counts, when you're running a charity.
Oh yes, oh yes, oh yes.
Pankaj, any plan to do outpatient knee surgery which can be reimbursable under senior citizen, because there'll be highest growth for all of us 70 plus for knee and hip replacement. So if they are covered and outpatient, it will save you money and have them save the money because they don't need to admit one day early.
So that's a very good question, and I don't have an answer to that because so far, as I mentioned, only inpatient is covered. Outpatient, there is a challenge in terms of availability of data for actuarial analysis, and that applies to PMJ, Pradhan Mantri Jan Arogya Yojana also. So that is the reason they created HWC, which is Health and Wellness Centers. So whatever outpatient can be covered under Health and Wellness Centers, at least you have. But what the question you're asking is surgical centers, daycare surgical centers. So
we call observational unit also. We have people who are there for less than 48 hours. We call it observational admission. They are not inpatient. So the reimbursement is less. More than outpatient, but less than the inpatient. So I think that's something you may want to consider. Sure.
See, I actually, did my work, and now I continue to be an advisor to NHA, but I'm not an, active operations there. So there are operation level people who are.
You still have relationships. So you are the pioneer. So I'm sure you can influence other people.
Sure.
Yeah. Thank you, Dr. Bindu. Thank you, Pankaj. I think that's a wonderful idea. So maybe we can talk about that offline and see how we can work on that. So Arun, Rajesh, both of you have been very actively associated with these programs.
Hi,
Do you
Kishan
want to
ji.
come and talk about your experiences, your observations? Arun, you want to go first, or
I think let's just keep it very brief because we're already over time. Yeah, and so I think I made a couple. I mean, I can only make general remarks at this stage because we're not discussing a specific issue, right? So technology, Ayushman Bharat in particular, cuts across everything, and the adoption is very, very critical to solve the problems that we have discussed. Right? Adoption, of course, depends on a lot of things, but it also depends on how each of us as a stakeholder perceives our role in the healthcare system. At the moment, we don't, we take a very limited perspective of our own roles in the system, not realizing that every piece of the jigsaw fits to completely make the healthcare system. And it's pointless to discuss private and public and trust and all of that stuff because all of it eventually fits together, right? So the adoption of technology, of course, there are economic reasons. There are lots of other factors as well. But I can only request people to have a far more proactive attitude towards adopting technology. That's what I can say for today. I mean, of course, this is a very deep subject and there's a lot to be said in many different ways. But yeah, sure. I mean, I would think there's a lot for the state to do. There's a lot for the government to do. There's a lot for everyone to do. But given the scope of this discussion that we have in this panel, the kind of people that are there, I think we need to take a larger perspective, take a more proactive role in looking at adopting technology, because at the end of the day, it's the quality and the speed at which data is available, which will allow the system to deal with the problems that we are talking about. And affordability is basically composed of two things. One is access and the other is sustainability. When I say sustainability, for every stakeholder in their own perspective, it has to be sustainable. And that's what will make for affordable healthcare. Thank you.
Thank you, Arun. Yeah, adoption has many challenges. I think one of the key challenges that I see in a lot of government programs is orientation towards citizens. The citizen-centric approach to policy making is extremely important. So while it's a great idea to have data standards, and so obviously they're going to be very helpful, many times I feel we are imposing a first world solution to a third world problem. Right? We probably need more fundamental reforms which need to be brought in to, like Dr. Ketan talked about, empowerment of physicians, doctors, and obviously there are a lot of documentation related issues which are there. But In any case, that's another topic. I don't want to go into detail here. Rajesh,
Yeah.
you have any lasting comment?
Just one thing that I'd like to add before Rajesh comes in, that with the benefit of hindsight in recent years, I've been doing a lot of work in public health in terms of, creating a demand for healthcare. I think what in this entire scheme of things, the behavioral science aspect has been neglected a lot. And behavioral sciences are very important to make all these pieces work together. And we need to anticipate the behavioral challenges to answer people's why and stuff like that. It's a deep science. I don't think we have catered to behavioral science in this whole thing very well. I think that's something that we could add. Over to you, Rajesh.
Thank you so much. Just referring to the last slide which Dr. Pankaj presented, which was so overwhelming that even on the presentation it looks very complicated, right? And just imagine implementing it on the ground with that complexity, which was very difficult to portray in a slide. So here we have two aspects, two perspectives. One is private and one is public. So while digital adoption in private hospitals have reached some level of success and maturity, I'm saying some level very carefully because it's a lot to achieve there. One problem is the public sector hospitals is hardly automated, let alone being digital. So how that is going to be plugged into this entire gamut of thing is big question mark. Secondly, from a private perspective, like any program, any mission to be successful, it works only when there is a benefit to private healthcare, right? Like when GST happened somewhere in July 1st, 2016-17, that time I was part of a hospital that time. We had no choice but to implement it. Whether you are doing perfect implementation on day one or you are doing something, but July 1st, you have to be compliant with the guidelines. Whereas here in ABDM, we don't see any kind of timelines or anything getting mandated with the timeline. Maybe for that reason, I've just stated that we are far behind from adoption of technology, both in private and public hospitals. That could be the reason why government is not able to come up with a timeline. But without timeline or incentive, and mandate, this is going to remain as dream. If you see Pankaj's previous slide before the overwhelming architecture slide, the MDDS, I clearly remember we worked together, Dr. Pankaj, on that. It was worked on in 2013. It took 5 years to get notified in 2018. And today we are sitting in 2026. We don't know where MDDS is in this structure. So while a lot of things have been done, but if we target to reach Cloud 9 on day one, obviously we are not going to. So if we can break Ayushman Bharat Digital Mission into smaller wins, which is much easier to reach, and once we reach there, we can probably take the next step, and so on. That could probably help us, increase the adoption. But it has to be one of the three things: mandate, timelines, and benefits. Patients are the biggest beneficiary for sure, but they don't even know what is happening with ABDM. They don't even know how it is going to help them.
Yes.
Even if I have ABHA ID, I don't know what to do with ABHA ID. So awareness training is another aspect. With one of the points that Dr. Pankaj already mentioned is how to create the capacity to handle this size of project or mission. So all that is open question. So while I am big believer that someday it will happen, but today I don't see the clear path or structure or a method to achieve that.
Thank you, Rajesh. I think you summed it up very well. I think that was a good summary, indeed. So as Arun said, we kind of already crossed our time today. A very interesting question. Thank you everyone for participating. And if you have any more questions, we're happy to take. Otherwise, we'll close the webinar here. Any more questions?
I think everybody was good. Rajesh, your comments were absolutely to the point. Awareness and implementation, they go hand in hand, and people should know what they are going to get benefit, and hospitals should know how to implement and the cost structure, because EHR are not easy to implement. And since we have a lot of private small hospitals, they all need to be taken into consideration, and implementation will take longer time. But I appreciate what you have done for last 10, 12 years. It's never too late. It's always good to start something which is going to benefit the mankind. Technology has to be adapted, whether we like it or not. We doctors are the worst. When this stethoscope was discovered, we are the first one to reject it. So I think we need to have doctors have to change.
Yeah.
IITians are the brightest. We doctors are 1-to-1, and we always resist. We are like pilot. We are in charge of the life, so we don't adapt the technology, which is good for the humankind. Thank you.
Thank you.
sir. Thank
So
you.
saying
Thank you,
that
everyone.
to learn more about it, I don't know what would be the platform where I can learn about all this, digital part of the Ayushman Bharat scheme.
Sure. What we'll do is maybe we'll try and also list a set of resources that you can access. So,
Right.
Pankaj, can we do that? And so, Anil, have you registered actually, or have you just got the?
No, I registered today.
General,
Only
I need to
an hour
move
back.
on to another meeting, guys. So
Yeah,
allow me to.
sure. Yeah, no, we're logging out. We're all logging out. So,
Right.
just I think that was the last comment. So, thank you everyone for joining, and we'll create a list of resources that we can share with everyone. And obviously, as Pyramid is saying, inertia is a very good, strong trait.
I think this is very well said.
That's true for all everybody. Thank you everyone for joining. Thank you so much.
Thank
It's a pleasure.
Thank you.
What a lovely discussion. Right.
Thank you so much.
Yeah,
Bye-bye.
Jyotsna, yeah, this architecture looks good, but I think the timelines have to be set up to do all this kind of work. It's lots of work.
Yeah, Jyotsna, I completely agree with that. So,
Yeah, I
Jyotsna
appreciate
is also
Pankaj.
from IIT Delhi, Bindu.
Yeah, my
and
camera is
she's
not
also part
coming
of
up, so you can't see me
part
right
of
now.
IIT.
Maybe in the next meeting, I'll try
Yeah,
to
she's
set it
also,
up.
thank you, Jyotsna, for participating.
Yeah.
Thank you, Pankaj. Arun has left. Rajesh has left.
Pankaj,
Thank
will
you,
stay
Pankaj.
connected. I think we have a lot to learn from you, and whether
Yes.
you are doing it now or not, but Rajbir will keep us in touch. We
Sure.
want to make it easier for doctors and the patients.
Sure. Absolutely.
Thank you.
Love to stay in touch.
Thank you, Pankaj.
Thank you. Okay.
Yeah, absolutely fantastic presentation.
Bye-bye.
Thank you, Dr.
Bye-bye.
Bindu, for joining and making it very lively. Actually.
Thank you.
so much.
Bye-bye.
Thanks. Yeah, thanks.
Bye, everyone. Bye, Jyotsna.
Bye. Bye.
Bye-bye.
Anjum,